Swati ma'am, go ahead.
Yeah.
Hello.
If your eye, your body, with very picky national conclave spotlight on impaired. COVID-19 has had a tremendous impact on the eye care delivery across globe, and hence not surprising, has made a very significant impact on ophthalmology in India as well. Lockdown was declared in India on 24th March for a period of 21 days and then subsequently extended for 5. Since then, patients have been willing to postpone their instead of taking the unnecessary risk of contacting the virus at clinic and hospitals. This pandemic and its consequent restrictions also bring immense financial, logistical, and psychological challenges to the patients. And they face difficulty in finding simple transport to the hospital, need to maintain all the rules of social distancing in public setting, and may have difficulty using masks. They may also fear being prosecuted for revealing their travel history or fever during the mandatory questionnaire at the hospital. All these factors make a simple visit to the hospital very tedious unless absolutely mandated. In a survey done 2 months earlier, majority of the ophthalmologists in India were not seeing patients during COVID-19 lockdown, with near total cessation of elective surgeries, and were unsure about the resumption of the surgeries after cessation of the lockdown. There were reduced footfalls of OPD walk-in patients. Only emergency cases were being seen in the OPD and for surgery. Outreach services were stopped, largely impacting the rural communities. Non-cataract conditions like DR or glaucoma patients have been affected during the break-in follow-ups. Financial health of the hospitals has been impacted as there is a dip in revenue on one hand and rise in expenses because of the PPE and other safety measures for the staff. Telemedicine, like smartphones, has become the lifeline for the consultation. For follow-up on the cataract and other surgeries, doctors are using WhatsApp images. For poor patients in remote rural areas with no phone, this option is also not there. In remote areas, rural medicine supply for cataract surgery patients has dried up. Hence, as COVID pandemic rages in the country, visual impairment could turn out to be one of the biggest challenges facing healthcare proxy. In fact, in number of in A or street, considering its concerns related to the conclave assumes a great significance. I'm happy that we have such eminent experts from this domain today with us to share their thoughts and perspectives. Today, as part of the National Conclave, we'll get an opportunity to hear the perspectives of Ministry of Health and Family Welfare, followed by special talks from senior representatives of prestigious organizations working in domain of eye health. This will be followed up by a panel discussion of experts on patient-physician collaboration to manage eye disorders. So without taking much time, I would like to invite Dr. Narottam Puri, who is Advisor FICCI Healthcare Services. He is also former Chairman NABH, Advisor Medical Operations and Chairman Fortis Medical Council, Fortis Healthcare Group. Over to you, sir. Sir, you are on mute.
Good afternoon, ladies and gentlemen. Respected Shri Nilambud Sharanji, Economic Advisor, Ministry of Health and Family Welfare and Joint Secretary, National Program for Control of Blindness. Government of India, Mr. Mohammad Bashir, former Kerala Education Minister and Honorable Member of the Parliament, expert speakers, doctors, healthcare providers, healthcare officials, patients, and patient advocates. The only thing worse than being blind is having sight but no vision. So said Helen Keller. We at FICCI have always believed that it is necessary to have the vision to plan ahead, to perform the endeavors which help the nation in not just promotion and prevention, but also in screening and early intervention to get to the root of the problem and to improve the quality of the services that the healthcare industry offers, along with safety, performance, and accountability. At FICCI, we are the bridge between the government and the industry, and we work very closely and try to enhance outcomes through multi-stakeholder deliberations such as the one that you were a part of today. It gives me immense pleasure to welcome you all to the FICCI National Conclave entitled Spotlight on Visually Impaired in the wake of COVID-19 being organized by FICCI. As Swati has rightly pointed out, COVID as a pandemic has affected each and every pore of not just this nation, but the entire world. And it is only necessary to understand that the people who are visually impaired are not going to be out of it. How to alleviate their suffering is an important consideration, not just now, but is going to be an important consideration for healthcare providers in the future. I am therefore very thankful to Novartis India, Vision 2020, International Agency for the Prevention of Blindness, IABP, the Retinal Society of India, and the All India Ophthalmological Society for supporting this initiative of FICCI. You all recognize and we all remember that India was the first country to launch the National Program for Control of Blindness in 1976, and we managed to reduce the prevalence to 0.3 by 2020. But when you consider that we are a nation of 1.35 billion, 0.3% is still a very huge number. We need to compliment the Ministry of Health and Family Welfare that the National Program for Control of Blindness has been one of its most successful programs. I'm sure we would get to hear more about this program from Mr. Nilambud Sharanji. I'd also like to set your sights on two major milestones over the last couple of years. According to the National Blindness and Visual Impairment Survey, India 2015 to 19, and I'm quoting here All India Institute, the prevalence of blindness in populations above the age of 50 years dropped to 1.99%, nearly 2% in 2018 from 5.3% in 2001. That is within a space of such few number of years, a significant drop. Visual impairment also reduced to 13.73% in 2018 from 32.1% in 2001. India, as you all know, has successfully met the WHO target of 25% reduction from 2014-19 visual impairment from the baseline level of 2010. That is what the survey found. It really looks encouraging. But where do we stand now? Despite decades of efforts and initiatives, the estimated prevalence of blindness, as I said, stands around 2%. Severe visual impairment at 1.96%, moderate at 9.8%, and moderate to severe at 11.77%. This is data which is extrapolated from 31 districts of 24 states and was released in just October 2019, less than a year ago. While the government programs clearly underscore the importance of universal prevention of blindness, the objectives cannot be achieved without the participation and support of all, including the private practitioners and the voluntary organizations. As we all know, the major cause of our problems of blindness in this country is a very simple treatable condition, cataract. This affects most people above the age of 50, and the condition causes about 66.2% of blindness cases, 80.7% of severe visual impairment cases, and 70.2% of moderate visual impairment cases. In this too is from the All India Institute of Medical Sciences survey that I referred to a little while ago. Interestingly, all this could have been avoided because 93% of blindness cases and 96% of visual impairment cases in this age group are avoidable. And the important point to remember is not that if it does occur, it is treatable, curable. The picture is similar in some of the most prevalent retinal diseases. And this is an important segment as India ages. And the condition is called age-related macular degeneration, that is AMD. With the rise in the aging population, you can expect that by the year 2030, there will be about 1.5 million AMD patients and 5 million DME patients in the country. Again, most of these patients are treatable with newer advances in science and therapy. According to WHO, effective interventions are available for health promotion, prevention, treatment, and rehabilitation to address the entire range of needs associated with eye conditions and vision impairment. What we need to understand and learn more about is, particularly during these times when COVID is affecting a major proportion of the world and is causing changes in our behavior as far as social behavior is concerned, and certainly health behavior, that the resultant delay in the treatment because of the multitude of factors imposed by the pandemic are actually going to cause a huge dent in the way the blindness prevention program goes forward because of the delay in getting to the practitioner, or on the practitioner side, the delay in providing for the surgery or whatever treatment that is required. Therefore, it is a very timely concept to have this national conclave on vision control. This can turn the spotlight on some of the critical issues and the challenges that face not just the patients, but also the providers. Amongst the older people, diabetics, heart patients, this is a very challenging time. And these are also people who suffer from these conditions, such as the ones that I referred to. Government approach, new advancements in eye care technology, and increased awareness in COVID all need to be factored in and understood. And I hope that by the time this conclave is over, we'll all be clearer. It is my proud privilege to extend the best wishes to FICCI for organizing this conclave, covering the entire spectrum of eye care and getting the focus back on patients during these times. I'm very sure that this eminent panel of speakers and experts will discuss the most critical issues, and we'll all benefit from the participation of these people who are doyens in their field. My best wishes for the success of this program, and I look forward to more dialogues to achieve the goal of universal prevention of blindness. Together, we can do it. Thank you very much.
Thank you, Dr. Puri. It was indeed a very encouraging address for all of us. I now invite Shri Nilambar Sharan Sir, Economic Advisor, Ministry of Health and Family Welfare, and Joint Secretary, National Program for Control of Blindness and Visual Impairment, Government of India, to deliver the keynote address and share the perspectives and approach of Ministry of Health, domain of eye health. Sir, we all look forward to hearing from you.
That National Program for Control of Blindness and Visual Impairment was one of the first programs launched in the area of non-communicable diseases, and it has its successes. A lot of considerable achievement has been made since the launch of the program. There is a considerable reduction in the incidence of blindness as well as visual impairment, to which a mention was made by Dr. Narottam Puri. And we are on course to reach the targets that we have set for ourselves as a nation and the global targets that are before us. In the prevalence of blindness, as Dr. Puri said, from 0.62 in the year 2007, we have come to 0.36%. And we are very close to a target of 0.3% set by the World Health Organization, and our own targets of 0.25 by 2025. So we have been doing this, and one of the main components of our national program is cataract surgery, which is the leading cause of blindness in the country. 2/3 of the blindness is caused by cataract, and under the program, we are conducting about 65 lakh cataract surgery every year. It has other components also, and we are also realized that with the lifestyle changes, newer kind of eye-related issues have also come up, and therefore new procedures like diabetic retinopathy, retinopathy of prematurity, glaucoma, these have all become a very, very integral part of our program. Aging is also an issue which has implications on eye health, so that is also being taken care of. And coming to COVID-19 pandemic, it has affected all of us, and it has certainly affected delivery of non-COVID health services. Government is very, very conscious of this. Detailed guidance note on delivery of essential non-COVID services have been issued to all the state governments, UT administrations, and state-wise reviews have been held on how these services are slowly getting restored. Specific to blindness and visual impairment, a very basic guidelines were issued in the month of March, but we are coming up with a comprehensive guidelines for delivery of eye care services during any pandemic like COVID-19. So this is what I wanted to share from the government side. I'll be here for some time. Unfortunately, I have to join another meeting. So I'll listen to some of the speakers for another 10-15 minutes and be benefited by that. And I certainly look forward to recommendation and suggestions coming from this webinar, so that we also get to know as to how to improve our service delivery and our outreach. Thank you.
Thank you, sir, so much for sharing these insights. I would like to invite Mr. Sanjay Murdeshwar to deliver the trigger talk on Netra Nirbhar during COVID times. Mr. Sanjay Murdeshwar is country president Novartis India and is also responsible for the pharmaceutical business. He comes with more than 20 years of experience in the healthcare industry, which includes varied roles in the pharmaceuticals and consumer healthcare businesses at country, region, and global levels. Over to you, Mr. Murdeshwar.
Thank you so much, and thank you for having me here. And good afternoon to everybody. Greetings, first of all, to the Honorable Economic Advisor, to the Ministry of Health and Family Welfare and Joint Secretary, of the NPCB and VI, Shri Nilambut Sharan, really appreciate it. Dr. Tar Prasad Das, Dr. Vishali Gupta, of course, Dr. Narottam Puri, Dr. Faninder Babu, Dr. Raja Narayanan, Dr. Mahipal Sachadev, and Dr. Ratna Devi, industry colleagues, friends from the media, and most importantly, all our participants who have joined us for this discussion on the impact of COVID on the visually impaired. The quote that really best defines how central well-being is to human happiness and prosperity was probably coined around 2000 years ago by the Roman poet Virgil, when he said that the greatest wealth is health. The COVID-19 situation has certainly brought this very starkly to us around the world. It has not only strengthened the understanding of healthcare needs in India, but also has forced changes to the ecosystem. Some are reversible, and I'm sure some are possibly irreversible. For many of us, the fear of this unknown has been far more daunting than unknown evil. It's the fear of the unknown that I guess is central to our impulse now. We fear contracting this virus so much that we ignore blatant symptoms and postpone or even cancel visiting a healthcare provider. We miss our appointments and compromise on the treatment. I must confess, I'm first to be blamed for such things. I've been trying to postpone some of these treatments as much as possible, not in the area of vision, but certainly in the other areas. Though all ailments are an issue and serious to the afflicted, affliction to the sense of sight is one which is absolutely fundamental, because they say that 80% of what we perceive comes through our sense of sight. So ignoring this sense has a massive impact on health and quality of life. I'll just give you an example. My aunt is actually medically diagnosed with age-related macular degeneration. It's a degenerative retinal disease. She lives in Nagpur with her 79-year-old husband. Their children, my first cousins, are based in the US. Recently, my aunt actually took a fall leading to minor injuries, unfurling major revelations for me. On inquiring how and where she fell, she told me that she fell on the staircase and managed to hold on to the side railing, which essentially saved her from rolling down. Now, one can say that at 74, it was perhaps her advanced years caused her to lose her balance. But on probing further, she mentioned she couldn't judge the height of a stair. Mind you, a staircase inside her home that she has been climbing up and down for over 4 decades. She underestimated its height as she was losing the sense of depth in vision. Further on, she realized that she had stopped watching television since it's not very clear. She was getting confused with medicine labels, and their home nurse was helping her with that. When we asked her when last she had gone to a treatment for AMD, she understood the problem. She had missed 3 visits to her retinal specialist. She chose to be silent about it since she feared going to the hospital due to coronavirus. And she knew that her children and her relatives, especially me, may pester her into getting her treatment. It's very sad and scary, but unfortunately, it's as near as that for me in the family. Every day we see how the elderly in our families can sometimes get unnecessarily anxious, most of them living alone or with an equally elderly spouse, consciously or unconsciously opposed with existential questions like, is this the end of life? Will I ever meet my children? And so on and so forth, when they hear about their vulnerabilities with the pandemic. While I must mention that my cousins have built a very stable ecosystem for my uncle and aunt and call them frequently, they never really ask a fundamental question sometimes. "Theek se dikh raha hai ki nahi?" Is your vision fine? Are you able to see clearly? But somehow that does not seem to be a very relevant question. So an important question that stares us at our face is whether there's a collateral damage that we are overlooking during this pandemic. In order to be very clearly Atmanirbhar, we definitely need to be Netra Nirbhar. India is, of course, a younger country due to our sheer size, but we are also, unfortunately, home to one of the largest and growing geriatric population, again, due to the sheer size that we have, with nearly 35% of them living with some form of visual impairment. That's at least what the Journal of Family Medicine and Primary Care tells us. We have 1/3 of the world's blind population, with cataract accounting for nearly 80% of blindness, and age-related macular degeneration ranking third among the global causes of visual impairment, with a blindness prevalence of nearly 9%. It's important for us to remember that our elderly are vulnerable mostly physically and psychologically. Their fear, anxiety, and apprehension need to be addressed, and perhaps regular check-ins by family members or caregivers are exceedingly important, and they have to include discussions around vision. At least I have learned the lesson the hard way. Unfortunately, this concern doesn't stop at our elderly. We have the second largest diabetes population in the world, 77 million to be precise. And we all know that diabetes has become the fifth leading cause of blindness across the globe. A diabetic patient is 25 times more vulnerable towards the possibility of getting blind as compared to a healthy individual. Diabetic retinopathy alone affects nearly 18% of the diabetic population in this country. And amongst these diabetic retinopathy patients, the prevalence of diabetic macular edema or DME is somewhere around 3 to 11%. That's a huge, large number. We also have around 12 million glaucoma patients, a condition that is not restricted to the elderly, and as we all know, is also a leading cause of irreversible blindness. Owing to low disease awareness and associated asymptomatic nature of the disease, the diagnosis rate of glaucoma is as low as 10%. So essentially, by the time a patient is diagnosed with glaucoma, 40% of the damage is already done. So these are startling statistics indeed. But friends, these are all before COVID-19 era. A recent paper which I was reading in the Indian Journal of Ophthalmology, based on a survey conducted among ophthalmologists in India during lockdown 1.0, as we called it, it really highlighted that 72.5% of the respondents of this survey were not seeing any patients due to the lockdown. So even as we are gradually opening up the lockdown and healthcare professionals are getting back to the clinics, patients are still delaying their visits. This may lead to worsening of the eye condition and may eventually lead to irreversible loss of vision. If we don't act now, it's difficult to really fathom what these statistics will look like in the years to come. At Novartis, we are committed to reimagine medicine to improve and extend people's lives. We use innovative science and technology to address some of society's most challenging healthcare issues. We discover and develop breakthrough treatments and find new ways to deliver them to as many people as possible. So during these unprecedented times, in collaboration with patient organizations and industry associations, we are bolstering patient education and disease awareness initiatives for those who are visually impaired. The fact that we are all gathered here today lays concrete the common purpose that all of us share. We absolutely laud the government of India, who have done a fantastic job for so many years in bringing in focus on vision and vision care and reducing the challenges that we have had. But we also hope that the government of India to be the torchbearers in prioritizing prevention of blindness. Given that the goal is to bring down the prevalence of blindness, it's imperative that all stakeholders embody the force required to make this nation Netra Nirbhar, with early diagnosis and timely treatment. So to take this message around eye health to the masses, we look upon the noble government to take forward the mantle as the most trusted voice in the nation. We, of course, will be right there to whatever is required. We at Novartis are committed to this purpose and are happy to support as knowledge partners for this endeavor. Again, thank you so much, everybody, for being part of this session. And we really hope to work with everyone to solve a very critical problem facing our country. Thank you.
Thank you, Mr. Minister. I would like Dr. Phanindra Babu to deliver his address on what does COVID-19 mean visually impaired. Dr. Phanindra is currently the CEO of Vision 2020, the Right to Sight India, based in New Delhi. Vision 2020 India is a registered not-for-profit eye care forum and is a key driver of the global initiative jointly by the WHO and the International Agency for the Prevention of Blindness, IAPB, for reducing avoidable visual impairment by year 2020. Dr. Phanindra has been working in not-for-profit organization sector for the last 20 years. Prior to moving to eye care, Dr. Phanindra led maternal and child health and HIV/AIDS programs that were implemented at scale across the country. Over to you, Dr. Phanindra.
Thank you, Swati. Can you see my screen, please?
Yes, Dr. Phanindra, we can see you.
Thank you. Okay. So, good evening, everybody. Thank you for this opportunity. Okay, so just a very brief about Vision 2020, the Writers at India. So, the India chapter has been formed in year 2004, and it is a national forum for eliminating avoidable blindness in India. And this is a collaborative efforts of international NGOs, national NGOs, eye care organizations, and the government to coordinate and advocate for improved eye care programs to achieve quality, comprehensive, and equitable eye care in the country. And this is the key driver of joint global initiative by both WHO and IAPB, with the primary objective of intensifying and accelerating the prevention efforts through policy advocacy and strengthening the eye care institutions. So we have the total blind population estimated at 4.8 million as per the recent blindness prevalence survey conducted by the Government of India. And while the total population with visual impairment, including the population with blindness, is estimated at 34 million. So let's just remember these figures. So we actually, the moment we think about COVID-19 or talk about COVID-19, the very first thing that comes to our mind is look, mask, wearing mask, the sanitizer, using sanitizer, and also frequent hand wash. While these are not any problem for anyone, including visually impaired, to follow, but there are issues being faced by the visually impaired, and they are adversely impacting their lives. So although I'm not aware of any quantitative study or any large-scale study about the issues faced by the visually impaired in the context of COVID, I have some qualitative insights as experienced by some of the visually impaired population. So they actually go along like a distress, stress, fear, anxiety, and some kind of the insensitive nature as experienced by the visually impaired population. The SCORE Foundation, which works with visual impairment, they had set up a helpline for guiding the visually impaired population on education, employment, and legal support, etc. Very long back, it's been a continuing effort. But since the COVID-19 crisis and the lockdown, all they have been getting are distress calls, with the stories of pain and desperation from the visually impaired. And they also said there are around 1,500 phone calls they received from the visually impaired, also experiencing that they have a high level of stress, where, because they're unable to understand what is happening all around them. And also the kind of the government, certainly the government websites, which have all information about COVID-19, but are not accessible to blind and visually impaired because it is not user friendly to the screen reader software, and actually sometimes they lead to the developing a fear and anxiety, and therefore the potential misinformation or misconceptions about COVID-19 among the visually impaired population can be corrected by appropriately or correctly sending the communication through proper communication channel, which is actually immediately important. I think this will reduce the fear and anxiety among the visually impaired. Also, there is insensitivity kind of certain cases in certain states. Some of the visually impaired population had experienced the insensitivity nature of the agents which actually distributed food during the food distribution time during COVID time. So that's also one more concern that actually people expressed. So this is actually psychological status of the visually impaired population during the COVID time, and the social distancing. Okay, so the social distancing, they can't practice social distancing unless they use a white cane to keeping a safe distance. But nowadays, even I think people are not willing to touch their white cane to support in navigation. So Mr. Rungta from National Federation of the Blind says, even the most well-meaning bystander may not be forthcoming with help due to the fear psychosis. And he also says we'll have to somehow convey a message among the public that if you, with all protection, help anyone, you're not risking your life or jeopardizing the concept of social distancing. I think this is very, very important message for all of us involved in the COVID response to sensitize and raising the awareness among the general public, which is actually a part of strengthening the support system, creating or the strengthening the support system. The other aspects of touch and isolation and access to information are also issues for the visually impaired. We know that touch is inevitable for visually impaired population. They need escort most times, and they have to touch objects on surfaces much more than an average person. And if they wear gloves, so they can still surfaces, but I think, but not, they cannot read braille. So even people are, having the access to, trying to access the elevator or, reading a book, which is actually braille dependent. And if they wear gloves, it is very difficult. So touch is actually a very a big challenge for visually impaired population to move around without touching any of the objects. And Mr. Abid says the official government information is not accessible to persons with visual impairment. And it says PDF files from different ministries are not accessible for screen reader users, and they make us rely on other people for to obtain information. And also for isolation may actually becomes even more challenging to the due to the dependence on others, and so tactile communication and the navigation is inevitable, and therefore making self-isolation more challenging for visually impaired. And he says, Mr. Mahantesh says technology can help, but unfortunately we are far behind. That is, and as far as the technology is concerned. So some more perspectives as we hear from some more people. Very quickly, I'll just take you through it. So Ms. Anupurani says, people are hesitant to offer them help. Her husband is also visually impaired, but that's their story. And also Mr. Subir Das, a class 11 student, he says, I can manage at home, by touching these doorknobs or switchboards, but I have to learn move around without touching anything when I go out. And also, one of the visually impaired persons somewhere in the country, ordered a can of water, but then she was told by the shopkeeper that she would have to get the can herself from the shop, which is a difficult one for anybody at that level. And also, students finding it difficult because they can't learn the mathematics as it is taught only through braille books and under the supervision of a teacher. This is also experience from the other experience from the visually impaired population. The service access, the bottom line is basically, so as per the RAP survey, this is service access. So we're talking about while we are coping, actually we are coping with the new normal. The national lockdown adversely impacted the lives of people with various eye diseases like cataract, glaucoma, and retinal diseases, and they are unable to visit a doctor for health checkup. With the restricted movements, lack of public transport, and further compounded by the no permission to conduct outreach camps, we expect more people to be impacted with visual disabilities and move from moderate visual impairment to the severe visual impairment category. So we know that rural population and people belong to low socioeconomic category suffer most, and affluent people and people in urban and metro areas, somehow they manage their healthcare needs. But what about rural and people belong to low socioeconomic category who are mostly dependent on government and public healthcare system? So we have the entire healthcare system, ecosystem, I think needs improvement as we adapt to the new normal. While it is good that government has formed guidelines and NGOs and private healthcare facilities adopted the new systems and technology, let us recall that we have a huge disease burden. For example, a cataract surgical rate. The current cataract surgical rate is only 5,300 in the country, national average, but against the required cataract surgery of 10,000. So here we have, I think, I understand that tomorrow probably our Honorable Prime Minister is likely to emphasize on the cataract backlog-free India program. And also we have the Allied Health Bill coming up very in the near future, which also makes a provision for telemedicine. And then we also have one more impact factor is that 39% of people got the cataract surgery done at the government facilities as per the recent RAP survey. So these points out to an important point that while the policy makers and the policies are being framed, we have the policy makers commitment. It is just that we need to make sure that these kind of policies are being implemented that seamlessly on ground. Therefore, along with the NGOs and private sector, which is actually generally in the forefront to adapt to the new systems and new scenarios and the new challenging times, the public healthcare system also requires adapting to the new systems and take the advantage of technology and be the role model to reach out to the needy on time to avoid any adding any further backlog and increase the service coverage. So the access issue, the communication access, also there are a few issues, some advocacy issues that are popping up from these experiences, as I just mentioned in the beginning. The current announcements primarily focus on the general public.
Kanindra, we have lost you.
Hello, we can't hear you, sir. Hello. Hello. Satyam, are you there?
Yeah, Dr. Kanindra, we are not able to hear you.
Yes, still clear. Suddenly it turned.
Hello.
Yeah, Dr. Kanindra, are you there?
Hello, Prince, sir. Are you there, sir?
Net must have got some problem, so it's not unusual for the net to cheat us. I don't
Right.
know.
So I think we'll move to the next speaker, and probably when he's back, we can finish off his slides. So
The COVID
now,
response.
I think it's coming back, Swatiji. If you can wait for a minute, maybe.
sure, we'll wait.
The slides are still there. His mic is not muted.
Hello, some the problem? Can I?
Indra, can you?
Kanindra,
Are you
yes,
there?
we can hear you.
Yeah, I can hear you, but I think my screen has gone off.
The slide has gone away from there.
Okay.
Sir, please share your screen again, sir. Just go to file and share your PPT, sir.
Yeah. I'm just taking. There's something going wrong.
I have given my slide to Swatiji, so I'm not going to share myself.
Yes, sir, we have you.
Okay. Can you see mine one right now? Is it okay?
We can see that.
Hello? Yeah, okay.
We can see that, Doctor.
So there are no exhaustive guidelines, as I mentioned, and I said the organization representing people with disabilities should be consulted on an ongoing basis to form part of the COVID response. And the other one is WHO says there may never be a silver bullet for COVID-19, and it says the wait was long and requires a sustained commitment. While NGOs and individuals have been contributing to mitigate the impact of the pandemic, the question is how long can such a model of assistance can sustain, and what is I think needed currently is an empathetic approach to devise a sustainable and efficient mechanisms for reaching out to different able population and particularly the visually impaired population. So we need to develop a support system that is feasible and practicable to ensure continued assistance and facilitation both within the healthcare and the community level. And so let's remember that while simply having a disability, any kind of disability probably does not by itself put someone at a higher risk from corona, but the visually impaired rely heavily on the assistance. We know that. But even during normal times, that is prior to the pandemic, access for the blind and visually impaired has already been poor. The greater risks may not be from actual disability, but from the disruptions in the services. So while planning the COVID response, let us consider the sensitive needs of visually impaired people and accordingly make service provisions. This will be great help to the community and to contribute to the improving the quality of life of visually impaired population. And as I mentioned in the beginning, a proactive approach in a new normal with adaptation to the new systems and technology is the need of the hour for every stakeholder serving the community. So thank you so much. I'm through. Thank you.
Thank you, Dr. Ramendra, for this special address. I would like to now invite Dr. Tara Prasad Das for his address on technology for last mile eye care in India. Dr. Das is currently the Vice Chairman and Faculty of Srimati Kanuri Sathan Center for Vitro Retrieval Diseases, LV Prasad Eye Institute, Hyderabad. He is also Fellow of National Academy of Medical Sciences. He is also Regional Chair of International Agency for Prevention of Blindness, IAPB. IAPB, ladies and gentlemen, is an alliance of civil society organizations, private sector, and professional bodies promoting eye health, advocacy, knowledge, and partnerships. His research includes both clinical, diabetic retinopathy, and infectious endopathology and public health ophthalmology. His recognition includes American Academy of Ophthalmology Senior Achievement Award and Government of India Civil Honor Padma. Over to you, Dr. Das.
Thank you, Swati. Can I have my slide? First slide, please. I don't see the slide myself here.
Yes, sir. Yes, yes. Just a minute.
I'm not seeing myself, so I'm a little confused. Okay, it's coming, I think. Yes, thank you, Amanji. Honorable Mr. Basit, Sri Saran, Dr. Puri, Sri Muddeswar, Dr. Mishra, Swatiji, and all my friends. The latest estimate of blind. Okay, next slide, please. It's fine. The latest estimate of blindness globally and India suggests that there are 253 million blind people in the world, blind or visually impaired, and 14% are blind. And India, last year estimate, which Dr. Puri and Mr. Saran spoke about, there are 62 million blind, of which 13% are blind, others are visually impaired. So percentage-wise, 14% blind in the world and 13% in India is not much of difference. Numerically speaking, as was pointed out by Dr. Puri, it is a very high number because of a larger population of 1.35 billion. Next slide, please. This is the still segmentation of the study that I just quoted. As the age advances before 50 and after 50, you can see that the refractive error, some of the disease changes, refractive error reduces by 56%. Cataract incidence of people above 50 increases by 184%, and diabetic retinopathy increases by 200% people above 50. When you prioritize the eye care in India, there are the four conditions. One is to first look at it, refractive error for people below 50, cataract and diabetic retinopathy above 50, without ignoring, however, glaucoma and the corneal opacity caused by non-trachematous corneal diseases, particularly corneal infections. Next slide, please. This is not unusual, keeping in mind that once upon a time, we talk only about the cataract refractive error, never considered other diseases were all kind of cataract centric. When published many years ago, they should go away from cataract centric. As you add diabetic retinopathy and glaucoma, our burden increases. So also, as the country India grows from a less developed to a more developed situation, and we are in the middle of a developing nation, so communicable disease increases and non-communicable disease increases and communicable decreases. So we have to have this larger burden of both the disease. We are in the kind of fulcrum where you have to look at either side of the coin. Next slide, please. WHO always talked about universal health coverage from 1978 Alma Ati Declaration, and they talk about primary health. Just last year, October, the World Health Organization published a wonderful booklet called World Report and Vision, which talked about integrated people-centered eye care, where you have to empower people and engage people in the communities, where you have to reorient the entire delivery model, partly actually done in India, and coordinate services inside and outside the sector. Don't of the eye and creating an environment which is both governmental and non-governmental. Next slide, please. Basically, it talks about a comprehensive eye care, which is committed to quality. It deliver close to doorstep, mind it, not at the doorstep, close to doorstep, and most important, the continuity of care. So somehow or other, this COVID might be a blessing that you might learn how to do a continuity of eye care by going closer to people instead of a one-off eye cams in future. Next slide, please. WHO, WRV, World Report Vision also talk about this enabling environment of 4-tier structure of eye care: community, primary health center, secondary and tertiary center. We in India, and LV Prasad particularly many years ago suggested, adopted by many countries around India. Next slide, please. That talks about 5 tiers instead of 4 because of a population country like India. A 4th tier may not work. We suggested that add one more tier for advanced tertiary center like AIMS in Delhi is or LV Prasad Hyderabad is. WHO did not define about the patient population coverage. We defined that properly, that at the community level to 5,000 people, exactly what health and wellness center you already declared by the Honorable Prime Minister. Then the primary care for 50,000 people, secondary for 500,000 people, then 5 million and 50 million. And in the right side, you will also see the division of the labor, where you can screen, where you can refer, where you can treat, where you can serve. Next slide, please. I'll give an example, LV Prasad. We personally, particularly follow this kind of tier system we advocated. That this map shows 210 locations as of last count that we had. Now actually we have 216, and this has got 4 larger tertiary center, 184 primary, and 20. Right, please. When you look at the data that what happened during the COVID time, as Dr. Nukela was talking about, our patient population in outpatient in the tertiary care, that is, let's say Hyderabad, came down from 51% in 2019, June, July, to 41% this year, this same period, 20% down. And at the same time, there's a rise in OPD population of secondary center by 10% and the vision center, primary center by 35%. This shows that people are most probably unlikely to travel longer distance right now out of fear, maybe tomorrow out of not necessity to travel. This has not translated significantly in a surgery because we do not do huge amount of surgery in a secondary or a primary center. But it's a question of time. We learn from this experience that how to take this positive, from this crisis to a positive statement. Next slide, please. And this is just not true for LV Prasad. I called my friends across India. There are eight not-for-profit non-government organizations. They got 401 vision centers, like we have 184. And the story is same everywhere in 12 states and 2 union territories. Next slide, please. So what is last mile? So we have to reach the last mile with how to reach there with the high tech and the high touch. A small, portable, digital equipment where technology can go to people instead of people coming to technology like happened before. So indirectly speaking, we're talking hospital at home. As far as diagnosis and treatment is concerned, surgery may not happen in a home definitely at this point of time. Next slide, please. How to do that actually? Now, the basic element for eye care, proper eye care, is comprehensive eye examination, just slit lamp, which is on the right side of my screen. Now, we have developed in-house a drone slit lamp where you do not need another expert to examine the patient, because when you put a slit exam in a vision center, right now do not have trained manpower, either optometrist or ophthalmologist to sit down and examine the patient. So we have a systematic system. And we examine somebody only puts the chin there, help the patient to put the chin against the bar, and we examine at Hyderabad. This is picture in Hyderabad. Examine the patient from here and communicate by tele audio system that what to do and what not to do. At this point of time, we have 16 installations like this in 5 states of India. We are still in a trial phase. The distance from the Hyderabad command center to this drone slit lamp center is between 37 kilometers to 883 kilometers. Next slide, please. Similarly, for refractive error, you have to screen, not that everybody refractive error. So in the left side shows something called a folding phoropter, where it's a paper-made simple device where somebody can screen whether you have or do not have refractive error first. And those who have right side something called EC, which is grown in homegrown in Madurai or lab, where you can actually refract and even dispense the glasses to large extent of time. Next slide, please. Next problem is a cataract. As we already know, that is the biggest, most important surgery done. Good to know that 89% of the IOLs used in India for 6.69, 6.7 million surgery done year for last is 89% is Indian made IOL. 5 companies make it. They not only make in India, they also export to 156 countries and 25% of global market that is. Next slide. And also, more than half of the population in India is cataract surgery done by the manual small incision cataract surgery, which is shown in the slide in meta-analysis that this is as good as a phacoemulsification surgery at a 6 weeks time. So that means they do not require a huge machine to do it, which can be done in a small secondary center. They don't have to come to a larger centers, be it Hyderabad or Delhi or somewhere else. Next slide, please. Glaucoma is a hidden disease. Typically, you diagnose glaucoma by an important test called visual field test, which is huge machine, bulky. We cannot get it from home. In our innovation center in LV Prasad, Hyderabad, developed a wearable you called ohm, order of magnitude, which we can sit down any place you like, and we can examine, and it is sensitivity of 85.5%, sensitivity of 80%. Similarly, in the country where there is a large amount of primary glaucoma which can be prevented by a simple YAG laser hole in the iris, it is also developed in India, which is marketed in India, so they don't have to be an expensive machine from outside the country. Next slide, please. And finally, the diabetes and other retinal diseases, we have our homegrown cameras developed mostly in Bangalore, 60% of market share. Pediatric retinal camera, 70% of market share in India. And the right side is the multi-spot laser developed in Madras, which works as well as a machine developed in Japan. Next slide, please. For these things, we have to first have a kind of a partnership and trust. One, academia and industry must partner, and they should not stay separately on their own silos. And similarly, as pointed out by Dr. Nukela, there has to be a very strong public-private partnership and trust that private also does as good as the public. The last mile, not all right, I'm fine. Last mile, it talks about the health for all. How do you go the last mile? And the homegrown technology developed in India and already used by many people across the country can actually take us to somewhere. Next slide, please. So that next slide, please. So they can reach even this unreachable. Now, this person, we cannot do teleophthalmology. We have to reach the person. Technology has to go to her house. This is a person we picked up in a tribal village of Orissa, one of the districts of Orissa. So thank you very much.
Thank you, Dr. Nath, for this address. May I now invite Dr. Raja Narayanan for his address on retinal disease to comprehensive eye care. Dr. Raja Narayanan is the director of Student Clinical Research Center, LV Prasad Eye Institute. He is also the Honorary General Secretary, Vitro-Retinal Society of India. He has more than 15 years of experience in the field of vitro-retinal surgery. Over to you, Dr. Narayanan.
Thank you, Swatiji. One request, I don't need my slides. If you can not show my slides, that would be good. There's a power cut here. You can see there's some darkness here. So we have to live with this. Well, it's not, I don't think it's about COVID-19 here, but once again, respected dignitaries and my dear friends, a very good afternoon to you all. It is my pleasure to participate in this national symposium on COVID-19 and visual impairment. Thanks to all the earlier speakers, we now know about the disease burden in India, but specifically talking about retinal diseases, we have quite a few diseases which are increasing in prevalence, namely macular degeneration and diabetic macular edema. In fact, diabetic macular edema or diabetic retinopathy is increased in alarming proportions in India, and we all need to tackle it together. Although cataract and refractive error still form the bulk of visual impairment, among the retinal diseases, it is macular degeneration and diabetic macular edema, with about more than 2 million patients affected in India at this point of time. 90% of Indians fear blindness, and this is no different from the world. It is but natural for any human being to be afraid of blindness because it takes away your independence and your emotional relationships with your near and dear ones. And the problem is now with COVID-19, patients who actually need urgent care are not reporting to the clinics. In fact, with only about 30% of patient volumes now being seen across most, at least eye hospitals in India, we are seeing more and more white cataracts or mature cataracts. And we are also seeing more and more advanced diabetic retinopathy coming in the late stages of clinic. And these are patients who know they have diabetic retinopathy, have earlier been on treatment, but they have missed their treatments during COVID-19 because of the fear of COVID. So these are not patients who are not aware of diabetic retinopathy. That's another big chunk altogether. So we are no different from the rest of the world in terms of fear of blindness, but where we are different is that in India, there is hardly any insurance coverage for eye disorders, for God knows what reason. But if you take Sri Lanka, Bangladesh, Thailand, I'm talking about SAARC countries, forget about Europe and US, we lack proper insurance coverage for eye disorders, and that needs to be fixed urgently with all stakeholders. The impact of macular degeneration and other any visually debilitating disorder is that it increases falls and depression. In fact, patients of macular degeneration surveyed, 30% or more had depression or anxiety because they cannot read, they cannot see, and emotionally, social interactions, gatherings, get-togethers, they just cannot recognize others in the meeting. And it also increases mortality rates. In AMD patients, the mortality rate is increased by more than 50%. What are we doing as a society? Vitreoretina Society has been increasing the awareness among the general population through advocacy in print and digital media, and also through FM radio campaigns about retinal diseases, diabetic retinopathy, and the most important thing about diabetic retinopathy being that it is asymptomatic. There are no symptoms till the last stages. You won't have pain, you won't have redness, you won't have watering. In fact, you won't have any eyesight problem until the last stage. So if you go to a doctor, before you have symptoms, the doctor can diagnose diabetic retinopathy before you have any symptoms. So that's the campaign that we are running. We did a survey among eye doctors in 2017 along with Vidal Health Insurance, and it gave us good insight about the overall care being provided by eye doctors in India, especially retina specialists. And all of them, the majority, almost 80% of their patient load is macular degeneration and diabetic macular edema. And almost 90% of them are treated by injections given inside the eye. And these are not one-off injections of 1 or 2 injections. They are multiple injections extending over many years, including the 4th year and 5th year, they may need treatment. So it's a chronic disease, and affordability becomes a huge issue. If it's a one-off treatment, we all know that patients can somehow plan for it. But if it's a chronic disease going into many years, it affects not just the affordability, also the family care providers also need to be prepared for that and get adjusted to it. And in that survey, we found that 80% of the diagnosed patients did start their treatment. Unfortunately, it's the continuity of treatment which gets lost. So most of the patients, when they come for a diagnosis, a problem, they start the treatment, get the first injection or the second injection, but after they get lost, they don't come for follow-up as is required by the medical guidelines. And here is where we need to have all the stakeholders, the pharma industry, in building awareness, providing high quality, affordable medications. The insurance companies, they need to cover treatments for eye disorders. I'm here not just talking about retina at this point of time, but a comprehensive eye care. And there should also be ease of documentation for patients. So there are lots of denials for whatever reason. I understand the insurance perspective, but it needs to ease out. We are now in a digital age, and things are pretty straightforward now for so many things, including app-based. I think documentation can be made much easier. What about corporates? Companies with large pools of employees also need to provide eye care insurance for their employees, and healthcare practitioners should make it as a reasonable procedure cost, educate the patients on insurance coverage, and actually guide patients to complete their treatment. We have also done work along with the IRDA, and thanks to a few interactions with FICCI also. Earlier, injections that were used for treatment for diabetic retinopathy or macular degeneration were not included in insurance policies, but now it's a great news for all of us that starting October 1, it has been included under IRDA guidelines. Exclusions not allowed. So macular degeneration is not allowed as an exclusion, and intravitreal injections have been included under modern treatment practices starting October 1, 2020. So what was the concern apart from, generally the eye disorders were not included in general health insurance coverage? We had to work out what would be the impact on the premium, because both from the patient's perspective, the risk pool of healthy patients actually supports the patients who are sick. So if you look at a base of about 10 lakh users of health policy coverage, that's a base of 1 million policy holders. If you were to cover for macular degeneration of up to 4 injections per year, the increment in premium is just 28 rupees, just 28 rupees per year for each policy holder for a break-even point. That's not substantial. So if you include, let's say, diabetic retinopathy or cataract, or even for that matter glaucoma surgery, I'm sure all of this put together, the increment of the premium is not going to be more than 300 to 400 rupees per year for each policy holder. Come on, that's doable, and that should be done. So what I'm here advocating for is, apart from retinal diseases, we should have a comprehensive vision care product for our population. People are paying a hefty premium for overall health insurance. An additional 300, 400 rupees can cover their eyesight, which is extremely important for anyone to lead a valuable life. And the other thing is that we need to work together with path labs, with other general physicians, diabetologists, because retina specialists or ophthalmologists alone cannot win this battle. In fact, they cannot even fight this battle alone. So as I had mentioned earlier, that 90% of Indians fear blindness, and we are no different from the world. But can we take a pledge today that starting our journey in 2020, that Indians will have better coverage for eye disorders than the rest of the world? Is that possible? I think it's perfectly possible and very much doable. With this, I would like to acknowledge Mr. Sanchit Nanda Sushant Anand from Novartis, our past president, Dr. Giridhar, our current president, Dr. Shobhit Chawla, AIOS president, Dr. Mahipal Sachdev, and also the Secretary General of AIOS, Professor Namrata Sharma, who have all throughout helped us in this journey. Thank you all very much for your kind attention.
Thank you, Dr. Narayan, for your address. With this, I would now like to start upon the panel discussion, patient-physician collaboration to manage eye disorders in COVID scenario. The panel discussion will be moderated by Professor Vishali Gupta. She is an accomplished retina and uvea expert of international repute, working at PGIMER, Chandigarh, India. She has delivered more than 900 invited lectures and conducted several instruction courses at various international and national meetings. She is currently the president of Uveitis Society of India and secretary of prestigious international Uveitis study group. And our panelists for the panel discussion would be Mr. E.T. Mohammad Bashir, who is Member of Parliament and former Education Minister, Kerala. Dr. Ratna Devi, she is the CEO and co-founder of Daksham A Health and Education, an Indian alliance of patient groups. Her work revolves around patient engagement and building capacities of patient groups to bring their voice to the center of policy making. Works internationally as the chair of International Alliance of Patient Organizations, improving patient access, and as a council member of ISQUA on patient safety and quality in healthcare. Welcome, Dr. Ratna. I'll also welcome Colonel Dr. Sanjay Kumar Mishra, who is Professor and HOD of Ophthalmology, Army Hospital Research and Referral. He is recipient of Seva Medal, Bhatu Vishisht Sena Medal. He is Senior Advisor Ophthalmology and Vitreoretinal Surgery. He was earlier HOD of Ophthalmology of Army College of Medical Sciences, Delhi. He is thrice recipient of Presidential Award. Welcome, Dr. Sanjay Mishra. I'll also welcome Professor Mahipal S. Sajdev. He's Chairman, Medical Director of Center for Sight. He's also President of All India Ophthalmological Society, which works for the promotion of the study and practice of ophthalmic sciences, research and manpower development, with a view to render service to the community and to promote social contacts among ophthalmologists across the country. He was honored Padma Shri Award on January 26, 2007. He's a renowned ophthalmic surgeon who is recognized for his expertise in the area of corneal, refractive, and cataract surgery. He is widely credited to be the pioneer in India propagating the technique of pharmoemulsion for cataract surgery and LASIK laser for removal of glasses. I welcome you all, and over to you, Dr. Vishali.
Thank you, Swati. At the outset, I would like to thank Vicky and my greetings to all the dignitaries present and helping us to sort out some of the key issues that we as an ophthalmologist and overall all the physicians are facing. So Swati has already beautifully introduced all our panelists. So I would move on to the next slide. Next, please. Yes. So this is the kind of the survey that CRISP has done as a real life situation and has been highlighted already by Dr. Raja Narayanan. Now, as you can see in this photograph, this is a patient with diabetic macular edema. And of course, the age-related macular degeneration patients have the similar problem. And then there are so many, but I would restrict to the results of the survey. Interestingly, the patients, 90% of the patients who were surveyed had this disease for 10 years or longer. 90% of them had symptoms. 81% had difficulty in reading and driving. And 63% were actually receiving regular injections before COVID. As a beautiful story told by Dr. Murdeshwar, that his aunt who was receiving the injection somehow stopped receiving injections. And the next point highlights that 100% of the patients have missed their visits due to lockdown. But what is of concern is that 85% are afraid to visit the doctor even once the lockdown is open. And this is what concerns us all, and this is why we are all here in the panel. 55% of them were interested in joining the patient support group, and 81% need some support for free consultation from the government. Next slide, please. Next slide. Yeah. So our collective responsibility, and the panel beautifully represents the representatives from all the walks of life, collectively what we wish to achieve. We wish to spread awareness amongst the patient about the nature of their disease and how important it is for them to have a regular treatment to avoid visual morbidity. And it's all the more important for us to have a collective efforts by the ophthalmologists, corporate sector, and the government to help not only increase the awareness, but we have to give them the roadmap, we have to provide them the guidance as to how the patients can actually report or approach the healthcare providers, all the while ensuring a very, very safe environment to that. Please end my slideshow, and with this, we move on to our panel discussion over the next 35 minutes. And we are truly honored to have with us from Kerala, Bashir Sir, who has been education minister and of course is the health member of parliament from Kerala. Truly honored to have you, sir. Sir, my first question to you is, the entire country and the entire world knows that Kerala is providing a truly exemplary high quality healthcare. What are the kind of the challenges that you were facing? Like, we would be interested to know in particular about eye, if there are any challenges that you have in particular, and what will be your guidance to rest of the country to learn from your state?
My dear friends, the chairman of the panel and my co-panelists, experts and brothers and sisters. It gives me gratification in attending this very important conclave. Very purpose of my attendance at the meeting, this conclave, is to get authentic feedback from you, because I myself is the member of the consultative committee in Parliament on social justice. All these kind of subjects are coming in our consultative committee. If I get a very effective feedback from the experts, I may be able to present it in the proper committees and matter at the appropriate level of the Parliament. That's my intention. And I hope that you will give the full recommendation of the meeting or the debate, full details of the debate. I assure you that we will make use of that in various appropriate forum of the Parliament. Now, towards your specific question on Kerala's experience, I would like to tell you that we are very much concerned about this kind of things. We are having very good institutions for visually impaired students, and all these institutions are working well. I can suggest a model to the entire country that this visually impaired persons and other physically handicapped and all the kind of people, there is a reservation in employment. That is as per the Act only. Unfortunately, that has not been effectively implemented in various states. That is the position. But in Kerala, we made it a part of PSC appointment, because we changed the law, and at the time of employment, this particular reservation category also will be filled through that process. So nobody can now escape from that. So that change we have made. I also suggest that we must have such a what is called like a link with PSC appointment mechanism with this. That should be a kind of statutory kind of thing. Then only that gap can be filled up. Now, towards the other thing, I would like to say RPW Act. That's very poor. We all say that's a very revolutionary step we have taken. Unfortunately, the implementation process is dead slow. Then this relaxation on duty now in the wake of COVID-19, we have to give, we have to press for some relaxation in work of the various employees who is having this this kind of blind kind of people. Then financial assistance for self-employment, things like that. That also, I think we must give an emphasis on this. Then similarly, that in this, we know the most affected group in the visually impaired section is like hawkers, doing others who are doing small business, MSME and like that. For that, even though we say that there will be encouragement or incentive from the part of the government, that part also is very much neglected. Similarly, our learned Dr. Tara Prasad ji was saying about the various technology kind of things. That's an area where we have to address very seriously, because I understand in other countries other than India, this kind of electronic kind of devices and all kind of technologies are coming, developing like anything. Unfortunately, in India, I feel that that has up to the expectation of ours. India is a fast developing country, and our technology side also, we are very proud of it. But unfortunately, with regard to this kind of people, what technology can be applied? That question we have to be very serious in about that also. Similarly, Dr. Raja Narayan was saying about insurance scheme. Actually, it's a major mistake on our part. Insurance for the visually impaired person, it is inevitable and is very, very essential in that. For that part also, as politicians and members of the parliament, we can influence the government also. We will take up that also. These kind of certain things are there. I don't want to take much of your time because other panelists are also going to speak on this subject. Anyhow, I will tell you, you kindly give the full details of the discussion, deliberation details, everything we will take up. And as a humble servant, I am also closely associated with visually impaired people. During my ministership, I have done many things for this section. I don't want to narrate all these things. I am also dedicated to this cause. I am really grateful to Vicky and the other hosts for inviting me for this. Actually, I took initiative to come for this, not with your this thing invitation. I thought that I am duty bound to attend this kind of meeting so that I will get new dimension of knowledge, and I will get proper feedback from you that can enrich my work in the parliament also.
Thank you, sir. Thank you. We truly appreciate you summarizing the need for decentralization, the application of technology, including artificial intelligence, the need to look after our visually impaired, the need to look after our staff. In short, within few minutes, you have summarized all. We are truly thankful and we look forward to your inputs and taking our cause forward, sir. We will definitely send you the detailed presentation of the minutes. Thank you, sir. Thank you very much. So now moving on to the patient aspect, we move on to Mrs. Ratna Devi, Dr. Ratna Devi. Ma'am, my first question to you is, you know patient's perspective, which truly sometimes we might miss. So what are your insights from eye patients' perspective during COVID time? What are the biggest challenges they are facing to reach the healthcare provider? Ma'am, you are muted. You need to unmute, yeah.
Can you hear me now?
Yes, very
Thank
well.
you. Thank you, Dr. Vishali, for asking me that question. And thank you for showing that first slide, which actually highlighted what the patients think and feel in COVID time, especially for people who have low visual acuity. And just to highlight that CRISP that was mentioned there is an acronym which stands for Community of Retina India to Support Patients. So this is meant to be a patient group. And as many of you would be aware, patient groups in other disease areas have really worked very well to bring patients together to discuss problems that are common to them and to seek answers. So in terms of what do patients experience during the COVID lockdown, and now that there is an unlockdown, on 29th of July 2020, there was a partners meeting, health partners meeting that was organized by WHO CRO, where it was mentioned that more than 50% of the countries in the region reported a disruption in healthcare services. Earlier, we heard that there are guidelines, but then there is no regulatory mechanism to follow up who's actually implementing those guidelines. Add to that the very horrific, media visuals that you get through various social media, print and electronic media. It adds to a combination of fear and distrust in the minds of people in the healthcare systems. There is such an overload of misinformation doing the rounds, especially videos of poorly maintained hospitals and wards with very sick patients, that even the most sturdy person would be scared of going to a hospital. So if you're an old person and visually impaired and have other challenges, then probably the thought of going to the hospital is so scary that they will not even think about it. Also, most of these people are living alone and therefore are unable to travel. They do not have travel support, or they do not have neighbors or children who can take them to a hospital. The public, facilities for travel are suspended, and many of them cannot afford the private ones now that some of those private providers are working. Many of them are dependent on their children for the financial aspect of it, and this COVID has brought in such disruption in economics at both at the personal level as well as at the family level, that even if children were supporting earlier, the priorities have shifted now, and therefore, many children are unable to support their parents. Also, even if there is a financial, ability, their priorities in life have shifted. So many of them are busy trying to survive their day-to-day lives, and going to a hospital and getting an injection or getting a treatment is not the top of their list. And this is the reason why we find that even the most aware, educated patients who know that, not going to a hospital might lead to worsening of their condition are not taking the plunge and are not going to their doctors.
So, Dr. Ratna, that's the genuine problem. Elderly patients, even we are scared of asking them to come to hospital, to be very honest with you. So Dr. Mahipal will tell us how to provide a safe environment. But from your perspective, how do you think we can help to allay the fears of these patients to some extent, and to ensure that we provide them the facilities that they need to reach the doctor, be it at the corporate level, or be it at the pharma level, who wants to do it as a part of their social corporate responsibility, or be it at the level of the government. Because, we are amazing at making the policies, but given the volume of the population and the social structure and all, somehow those policies do not actually get translated into reality. So can you give us some simple practical tips that we as a as a whole group can help to bring these patients to the hospital?
Thank you, ma'am. I think the most important thing that we need to address is the lack of trust, and the person who the patient trusts most is their doctor. And I think the COVID has brought a disruption of communication as well between the doctor and their patients, because not only the patients but the doctors were also struggling to maintain normal services, and given the new challenges for social distancing and confirming the hospitals to the standards of universal precautions has all taken time. So I think the communication channel or the bridge needs to be rebuilt. So if a simple call from a doctor to their patients, if they have the patient details, and many corporate hospitals also use apps these days to send SMSs for regular follow-ups. So if there could be simple messages that could be crafted to send to these patients saying you are safe. The retinal hospitals or the ophthalmology hospitals are usually standalone and not the hospitals that you see on social media and other platforms. They have all the requisite precautions that are needed to keep the patient safe. I think it will rebuild their trust. The other recommendation that I would suggest on behalf of the patients is maybe collectively give a request to the media that too much of negative images is destroying essential services, and a lot of people are dying. It's not just the retinal diseases, but stroke and cardiovascular and all that. People are dying because they're just not going to the hospital for fear of getting the infection. So I think we need to send a collective message to media that there has to be some positive messages out there saying the health systems are ready to receive patients, all precautions will be followed, and we can always point out which are those hospitals that give these best services. That would be good. And of course, the third one, most of these people, since they are elderly and living alone, they need a ear. They need somebody they can talk to. So if we can create that kind of a social mechanism where they are able to talk to people, maybe they would share more. And the last point about managing the services, I think it's just a question of connecting the dots. There are many not-for-profit organizations that actually provide these services, especially ambulance and other services. If we can then reach out to them and connect the dots, I think many of these patients will be able to reach back to the hospitals.
Thank you. Thank you so much, Dr. Rathinam. Dr. Mahipal, as Dr. Ratna has pointed out that we are all, ready with a safe environment. So how do you think we are, Dr. Mahipal, are you there?
Yes.
Okay,
I'm here.
perfect. So how do you think we can boost the confidence of the patients post-lockdown to reach that safe environment? Right now, they are not feeling confident.
Yeah, thank you very much, Professor Vishali. That's a good question. Actually, what my earlier speakers have also highlighted is the age group that we are dealing with. So there is a wide variation among what a person is perceiving as a COVID threat. There are some people who would say that you just get over with it, have COVID, we are young, nothing is going to happen, and we'll get out. Like that's the typical kind of a mentality that Donald Trump is saying. And then there is a very, very fearful mentality among a lot of older people that, like somebody said, that will we be able to meet our grandchildren? For them, at times, people are thinking it's the end of the world. I think people are coming to grips now that we will have to survive and live with COVID. And if we take the proper precautions, as the numbers are going down in a lot of places in North India, the same is going to happen. Now, one important thing that was highlighted by my earlier speaker is that these people need to have confidence building measures, and that needs to be a concerted 360-degree effort where the media, whether it be the television, radio, whether it be the newspapers, etc. I've been trying to put together the industry and the ophthalmic societies to actually go on this 360-degree campaign, but obviously it involves money, which I have not been able to collect so far. But I think that is one particular thing that if we give the message to people that there are going to be issues if you do not get your normal treatment, like you very nicely pointed out, macular degeneration patients who were on injections, diabetic retinopathy, glaucoma patients, etc. And even for cataract, mind you, the number of mature cataracts that I am operating nowadays is much more than I ever did in the last couple of years. So I think that needs to be told, the message needs to be sent, and there is obviously going to be some involvement of being able to raise money. I think one important thing that we have to say is that standalone ophthalmology centers do not actually have COVID patients, because we have a screening desk outside, all of us. We check the temperature, we take a history, etc. And we don't allow any COVID positive patient with a history, etc. to come in. Obviously, there'll be asymptomatic carriers, etc. that come in, but the time frame that these people are going to be in the hospital or even in the OR, supposing if you're doing a cataract surgery or you're giving an intravitreal injection, you have a patient put a mask before coming in. You have a patient do gargles with the iodine, povidone iodine. Patient is good as regards the load. The load, if at all, even in an asymptomatic carrier, would be very, very minuscule. So I think, touchwood, so far we have not seen in the OR any transmission of COVID from any asymptomatic patients. So I think this message needs to go that the the time period that you have in an eye hospital is limited. Even in the surgery, it is limited. We don't have inpatients and we don't have COVID positive patients. So it is reasonably safe for you to come and visit the hospital and not ignore your visual problems, because that can lead to irreversible blindness. So I think it has to be a campaign that has to be done at a 360-degree level. And obviously we have a couple of write-ups that the newspapers have written, but I think more needs to be done.
More needs to be, more at the public level.
Yes.
Right now, like the guidelines and all that we have written, and AIOS has done a remarkable job, is mainly for the ophthalmologist. Probably as a next step, we need to gear up towards patient education. And Dr. Mahipal, there is a question from the audience. Sir,
Yes.
can you please throw some light about uncorrected refractive errors and how can optometrists get involved for the same?
Okay, so I think there are some good things that have come out of COVID. Obviously, it's a dark scenario, but there are certain good things. Whenever there is a manthan or whenever there is something big that happens, an event happens. So one thing that was in the works for, I would say, 10 years, that is the legalization of telemedicine. That has happened. So I think that is something which is very, very important. That you can now see there are now the next step is how to get digital eye care to the home, which Dr. P.T. Das was also talking about. So that is where home eye care that we need to, as ophthalmologists, tie up with optometrists. There are now methodologies, there are enough software that are available that I can project a Snellen visual acuity, a color vision, Ishihara chart. I can do a contrast sensitivity through the digital space onto somebody's even smartphone, or to do it on somebody's computer. In addition to that, as was shown, the model or whatever, there are national models also which are available, where you have portable auto refs that are available. You have portable phoropters which are available, and that is where the optometrist can come in. And there are other tests. For example, you can even have the optometrist help us do a fluorescein stain and see it on having. There are ways to have the blue light shining on the cornea to pick it up. There are portable fundus cameras. So I think a technician or a trained optometrist can be the last mile in home health and digital eye care delivery. So I think there is lack of great coordination between ophthalmologists and optometrists. We tried doing that in AIOS, and I think we should push that. The next stage is going to be adaptability. We have to be as fluid as possible to do that. So I think the era of tele-ophthalmology, of home health, is going to be something that we need to concentrate on. And I think if we can reduce the number of visits for non-essential things to the ophthalmic clinics, that would be something which will be good, and optometrists will play a key role on that.
Thank you, sir. I think this is the message which our Honorable MP will help us take forward, is to incorporate the teleconsultation, teleconference, decentralization, and to apply technology as much as we can to minimize the patients visiting the central hospitals. Now we come to the Army, and of course we have Colonel Dr. Mishra with us. Sir, people have always been more confident about Army than somehow us civilians. So how do you think Army is helping in managing the COVID and in particular the eye services during COVID?
Thank you, Dr. Vishali. Can you hear me?
Yes, we can, very clearly.
I have my slides, please. As we all know, that armed forces has always been in the front line, whether it is defending the country or in times of calamities like earthquake or a pandemic of this size, we've always taken the lead. In armed forces, we are often guided by the standing operating procedures, which are issued by our headquarters, and also incorporate the various AIOS and the VRSA guidelines. We have redesigned our OPDs, the systems and the process, to maintain a proper social distance, and the hospital exposure time is reduced. We have started teleconsultation and screening at the hospital entry to reduce the footfall in the hospitals. The drug dispensation, which is normally we give it to our patients, these drugs are given from the hospital free of cost to all our patients. And initially we were giving for 30 days. Now we have started giving for 2 to 3 months so that their further coming to the hospital is reduced. The new patients are isolated at the gate. The entry gate is strictly manned. We take the temperature and ask about the history. The moment a patient gives any history of any flu-like symptoms, he is immediately sent to the flu clinic, which is next to the trauma center. His immediate sample is taken, and once he's tested negative, then only he comes to the OPD. We believe in force preservation because we are working with a limited manpower, whether it is doctors, nursing staff, or the paramedics. So we provide them adequate PPEs. There is no dearth of PPEs in our hospitals. We do frequent surface decontamination and adopt contactless procedures. As far as continuation of care is concerned, we disseminate correct information. To the administrative times, we have a very close system of dissemination the information or through electronic media. We are actively contacting our patient by the respective departments. We have the various information of the patients with us, so we contact them regularly. And in case the patient is not able to come to the treating hospital, we encourage them to go to the nearest hospital, whether it's a government hospital or all those ex-servicemen. We tell them to go to the empaneled hospitals. We then do our medical audit to see what quality of care we are giving to these patients, and if there is any lacuna or a scope of improvement, we do that. We have a 24 hours COVID helpline facilities where the patient can call up the hospital and take guidance. And these facilities are available for most of our army centers. Next slide, please. As far as service hospitals are concerned, we are no exception. That yes, our patients are scared, and especially our elderlies who are ex-servicemen, they are scared, and we have seen a reduction of almost 60% of OPD. So we keep these patients aware at regular time, and we have classified our OPD into 3 groups. That is high-risk group, which are consulted. We give them a call, and each patients are individually counseled. Then there is a moderate risk group. They are sent information by SMS or on WhatsApp, and they are told that in case of any warning symptoms, they should immediately report. And the third group is the low risk group, where they are just send SMS, and since it's a non-urgent nature, they are advised to avoid visit to the hospital unless and until it's mandatory. We keep organizing tele-ophthalmological workshop for all our doctors, the residents, the staff, paramedical staff. We keep telling the patients how to monitor themselves, especially in cases of AMD and diabetic retinopathy. And we keep educating our patients when the patients are, especially if they have to travel, the patient who are coming from outstation. Next slide, please. So in hospital, how do we take care of our patients, whether it is a general precaution for all patients, and then we do a specific precaution for our eye patients.
Sir, I'm sorry to interrupt. Is there anything Army is doing in addition to what all is being done? Are these the same precautions?
Ma'am, we have formulated certain protocols of ours that since it's a very closed system, we have formulated our protocols, our screening procedures. We have created a center which is OPDs are not run in the main hospital. Since it's a multi-specialty hospital, we avoid the patient coming to the main hospital.
So you have the COVID versus non-COVID.
Yeah, we have a COVID versus non. We see all patients as positive unless and until proved otherwise. So we have
Mishra, For lack of the time, can I ask you one single message? And I would ask all the panelists, how do you see pharma companies, government, army, and different societies like VRSI, AIOS, working together to bring patients to the hospital? Just last question.
You are asking me, ma'am, or?
I'm asking you and then other panelists. That's the last question from me.
Can you repeat the question, please, ma'am?
How do you see all of us working together to bring patients to the hospital?
No, it has to be a joint effort as far as the hospitals, the pharma companies, and the government. There is a sense of fear in the patients. You see, when I see my patients, the patients refuse to come. Despite almost losing their eyesight, they refuse to come. So there has to be a confidence building measures that they are not going to get COVID just by visiting the hospital. It has to be implemented. They cannot lose their vision because of this fear. And once they come to a stage when it is beyond repair. So we have to build confidence now that cases are coming down. So the footfall is also rising now. I think gradually the patients are also understanding that the treatment at right time is most important rather than waiting, and because this condition is not going to get over in next maybe 1 or 2 years. So we have to all live with it. And I would also like to mention one more thing, ma'am, about the facilities what armed forces and the DRDO has done. It's a commendable job that in 11 days, the DRDO has raised a 1,000-bedded hospital, a fully air-conditioned hospital with 250 ICU beds, manned 24 hours 7 by the armed forces, and 3 more coming up, 2 in Bihar and 1 in Lucknow. So it's a commendable job by our Defense Research Development Organization.
Absolutely. We always salute the Army for what it does to us. Dr. Mahipal, last word from you. Where do we start? I mean, we all understand we have to do this. How do we start?
So I think I am doing it as President AIOS. I have written to the pharma companies. I think I haven't approached them that the situation is very, very clear that all of us as individuals have made video films, etc., and have given out messages on WhatsApp and social media to the patient. But I think until, of course, we put everybody together on a platform, and there could be an initial startup corpus of a 1 to 5 crores or whatever it is, and because it has to be taken at a much bigger to restore the confidence in the patient, where the messages of preventable blindness going up because of lack of visits to the hospital is going to be a problem. And as has been said, that we will minimize the time of the patients to the hospital. So I think we need to get together, and maybe all societies and pharma companies, etc., we need to push this message, and we have to redefine things. And I think we should also try to give consideration to the patients who may not be able to afford much, that there can be, for the time being, there can be deferment of charges, etc., etc. So I think it has to be a conversation that we can do that.
Sure.
And
yeah, Dr. Ratna will be there to convey our sentiments to the patients. And of course, Novartis is there. Sanjay is going to fund us with all this, and Vicky. So with this, I will pass it on to Swati for further carry on. Thank you, Swati, for the panel.
Thank you, and thank you to all the panelists for such a great discussion, very focused and very to the point and informative. Thank you so much. With this, I'll move on to our next talk on insurance standardization by IRDA, implications for coverage of eye disorders by Sri Srivatsan Aparajithan, who is the Managing Director of Intent Health Technology. Intent Health Technology is a company promoted by Vidal Healthcare Services. He's currently focused on helping hospitals improve their operating margins and strengthen their financial performance. Prior to Vidal Health, Srivatsan worked with companies like IBM and Apollo Hospital and has played an anchor role in development of the healthcare sector in India. He is well connected in the hospital industry as well as financial services sector, both in India and globally. He is passionate about preventive health and would like that no one should have spend money on avoidable medical treatment. Over to you, Srivats.
Swati, and can I request somebody to put up my slides? Yeah, thank you. Thank you for inviting me to this session. I'd like to first, Shri Mohammad Bashir ji, Honorable Member of Parliament, thank you for sharing your thoughts. Distinguished clinicians who are on this panel, industry leaders, and of course, friends in the audience. Thank you, Dr. Rajnarayan, for bringing in this matter about the lack of health insurance. So I just went and looked at some claims data. I compared the period April 19 to April 20. Some very interesting insights in that. So while the hospitalizations had come down by about 65%, ophthal treatments were virtually down to zero. In the month of July, we are seeing a slight shift. Ophthal treatments have gone up and are currently seem to be at about 1/3 of the volumes pre-COVID. Now, obviously, cataract seems to be a big part of what insurance pays for, and almost 85% of all hospitalization for eye disorders related to COVID, out of the total of about 50% of all claims relating to eye disorders. Percent is accounted for by retina. The next slide, please. So I went back to check all the eye procedures that are covered by the insurance policies, and I was pleasantly surprised to see that there's a fairly comprehensive list. There are about 18 surgeries that are covered by insurance companies already, right? So people do have access to treatment for eye disorders. Okay. However, what come out was that certain treatments like age-related macular degeneration or diabetic macular edema, which were on the rise, were not adequately represented. Next slide, please. Now, thankfully, the guidelines that the IRDA last September and allowing for coverage of some of these conditions starting October 2020 have addressed this. I was just reminded of the work that we did with the VRSI. Dr. Rajnarayan talked about it, where in addition to surveying a lot of the ophthalmologists, we also tried to socialize the matter with insurance companies, with the buyers of insurance, saying that they should specifically ask for cover for ophthal treatment and those conditions that were not present in that. Soon after that, we went and surveyed all the insurance policies, the health insurance policies that were available. And obviously, there are a fair number of insurance policies that are out there, both available to the corporate sector employees as well as retail consumers. And what we found was that a large number of policies actually provided comprehensive cover. The issue was the fact that they imposed sublimits. Now, if you look at the IRDA regulation, the guidelines issued in September, while they have said that macular degeneration should be covered and that intravitreal injections should be covered, they have allowed the insurance companies to impose sublimits based on their own product design. So what does this really mean? It means that while there is a reasonable coverage for eye diseases in the insurance policies, what could be limiting to persons requiring these treatments is the extent of that is available. And unfortunately, allowed the insurers to impose sublimits. Some of these policies for the intravitreal injection is total cover of only 20,000 rupees. Now, I heard clinicians talk about the fact that somebody might need 4 to 6 injections, and if the cost to be, say, a lakh of rupees, then clearly there is not adequate cover. Now, the point that I'm trying to bring out here is that the regulator has specific in the Arogya Sanjeevani product, which the IRDA said that is a standard product which all insurance companies must offer. They have said that up to 50% of the sum insured can be paid towards cost of modern treatment. Now, if you assume that something like, say, the intravitreal injection is covered under that, now if somebody buys a policy worth 1 lakh, only about 50,000 rupees is going to be paid out for that treatment. Now, which really means that even if somebody has an insurance policy which says, yes, I will cover the treatment, the matter about how much will it cover and is that going to be adequate to allow that policy holder to receive the full care without incurring any expense of it. Please. Yeah. So clearly, for the market to grow where every individual is covered under some policy or for the treatment that they must receive, there are a few things which I think need collective attention. First, of course, is that there has to be early screening, because oftentimes the visual impairment is not detected till too late. Now, as part of the work that we do with some of our large employer clients, we've always offered them eye screening as a service. Now, eye screening typically tended to focus on the refractive error problem, because clearly the corporate sector had large number of people who perhaps were not aware that these problems were already there which needed fixing. Now, when we did this project with the VRSI, we discovered that for early screening of age-related macular degeneration, there was a very simple test which could be administered online, which is the Amsler grid, and which allowed us to then take that to the large employers to say that perhaps this is something that you want to talk about. Now, obviously, in the workforce, number of people above the age of 50 is still relatively small, and therefore the applicability of that screening was not felt to be that much. However, we are also now starting to see increased cases requiring treatment for glaucoma. And so we have now started talking about dry eye screening, which we believe can be an early indicator. So early screening is definitely something which is important. Now, the second part is that there are policies available, but unless there is a collaboration that drives greater penetration, you want more people to buy insurance policies, and you want them to buy policies ahead, need these policies. Because if somebody wants to buy a policy after a condition has been diagnosed, there is no way they can buy that policy. So clearly there is a need for people to be made aware that they need to buy. Doctors also need to be more familiar with insurance processes, the newer kind of treatments. So for instance, newer treatments may require certain gating requirements to be followed. So a particular test needs to have been conducted if the insurer will process that bill. Now, if the doctor does not carry out that test, then there's a high possibility that the claim may be denied. And that really means that doctors must be fully aware of what screening that they must perform before they can recommend a certain treatment, which itself might be allowed. Also, the fact that there are people who may have policies but may have some doubts, and helping them understand. So either through help desks, which could be provided by the insurance companies, or could even be provided by pharma companies, which allow them to determine if they have a policy that covers them for a particular treatment or not. The last point I want to put out here is that how do sublimits keep getting revised? Sublimits get revised when insurers have higher quality of data in terms of utilization and pricing. And therefore, it is important that the data flow must be created. So as more people buy it and more people use it, and the insurance company starts getting more data, gradually the limits are shifted. That way, what can happen is that the coverage for some of these uh, treatments, which are expensive, can gradually start to go up. So I think it's a process which must necessarily bring together. So the IRDA has taken a lot of steps in the right direction, but now for the penetration of insurance to grow, for more people at the right time, etc., I think it's important that there is to be very high level of collaboration. Clearly, what I am talking about here is not just relevant from a post-COVID kind of a scenario. This is for both the medium to the, because only then will we have adequate population of people with policies that provide them adequate cover. And that really is going to be the need of the hour. Thank you very much.
Thank you. Informative address. India delivered the vote of thanks. To you, Chanakya.
Am I audible?
Yeah, you're audible.
Thank you so much. Thank you so much. I first want to start with the quote which Dr. Narottam Puri so aptly mentioned. And he spoke about that the only thing which is worse than having no eyes is that you have sight but no vision, by Helen Keller. I think today we tried to have a vision for these people who are visually impaired and are not able to get the kind of treatment which they actually require during these COVID times. We made some progress, we got some actionables, but it is also important that we use these actionables to turn it into reality so that we are able to impact the lives of the people who are suffering during this lockdown period. I therefore want to thank Dr. Narottam Puri for setting this context and highlighting the problem of the current COVID situation and the kind of damage and the kind of burden which it has placed on the visually impaired. I also want to thank Dr. Shri Nilambuj Sharan for talking about NPCB and committing government support for initiatives to help the visually impaired during this lockdown and COVID period. I want to thank Mr. Sanjay Murdeshwar to bring alive the problem of visual impairment and problems that people of visual impairment are facing with the example of his aunt. I think it personified it very well. And it gave us a slogan of Netra Nirbhar. And the collateral damage which we are causing because of this entire lockdown is quite disturbing. This Netra Nirbhar slogan is something maybe we can take forward. Dr. Phinendra Babu highlighted the psychosocial distress which visually impaired people are facing and how it is important for us to, as a society, to proactively reach out to the visually impaired and help them. I think one very important thing which happened here was the fact that it is also possible through technology that we take the hospital to the patient and not only wait for the patient to come to the hospital. And Dr. Tara Prasad Das showed that very well with indigenous developed technology, which has been developed in India, where it is possible for us to go to the patient rather than him to come to us. And so therefore, thanks, Doctor, for actually opening our eyes to this kind of a possibility as well. Dr. Raja Narayanan has truly highlighted the plight of patients which arise due to vision disorders. And it has gone beyond just vision disorders into falls, depression, and even increased mortality, which these people are facing because of these. Champion the cause of how we continually need an active insurance for these visual impaired people is something which he brought out very well. And we are also very excited by his announcement that private insurance is going to be covering anti-VEGF injection from October 1st. We look forward to that. And now coming to the panel discussion, I think we had a very, very fascinating panel discussion, which was led by Dr. Vishali, who moderated very well. And so thanks, ma'am, for highlighting the patient study of CRISP and setting the context that patients become very scared during COVID and they are missing their treatment and are placing themselves at risk of permanent damage. Our hearts actually went out to Mr. Mohammad Bashir, Member of Parliament, for so passionately talking about the fact that he is actually moved by visually impaired patients. And he is going to take up and champion their cause, not only in Parliament, but various other councils he's a part of. Dr. Ratna Devi gave us a very good idea of how the scare of COVID has impacted the patients from a patient's perspective. And they require an immediate trust building with the HCP community to get patients to move towards healthcare facility because they really require it. Unless they actually do this, there will be a significant permanent damage to their eyes. Dr. Mahipal, the president of AIOS, gave us a very clear understanding of how clinics are actually now prepared to receive patients and that the insight that the eye care clinics are not actually COVID centers and therefore they are well prepared to tackle this problem. And it is a trust. He also reiterated the fact that it is a trust which is actually required to bring these patients. Colonel Dr. Sanjay Mishra gave us a very clear understanding of how he has made Army hospital and clinics completely prepared during this period of time for handling patients and a risk-free environment, thereby helping them avoid permanent damage to their lives. And finally, Shishivatsan for giving us a detailed insight on insurance and visual impairment and how we can make insurance policies work right now and also in the near future. And finally, I also want to thank all the audience who has come at this point of time to hear us and to participate in this entire movement to actually do something for the visual impaired. I think it is quite possible if we all get together, industry, the society, the healthcare community, and the government together to make this possible, because this is a huge problem in the making. If and when the COVID situation improves, we do not want to end up with huge number of blind people, which can happen in India. So I would request everybody to take these points which we discussed and make some actionables, and let's have some of these to be implemented on. With this, I hand it back to you, Swati. Thank you so much.
Thank you. And with this, we come towards the end of the online session today. And we thank all the panelists and experts and senior representatives from various organizations who joined us today to share their views and perspectives on this very important. I think this spotlight was indeed a necessity for today's discussion. Thank you so much.
I thank Novartis and FICCI for this opportunity. Thank you so much.
Thank you.
Thank you.